You're good.
Well, hey, everybody. How's it going? How's it going since we were here last time?
So
Good.
Going good? Okay, well, you came back, so that's good. Thank you for that. So we're going to talk about a few things today. We're going to talk about documenting and coding insulin and non-insulin medications for our diabetic exams. And the importance of that. We're going to talk about documenting and the medical necessity for minor procedures, which can be a little bit tricky. So we're going to talk about that. We touched on it the last time. We're going to go into it a little bit more in depth this time. And we're going to talk about what we need to document when we see patients who are taking medications that our doctors may not have prescribed, like Plaquenil and things like that. What all needs to go in the chart, and what we're billing, and what needs to be in the chart for us to do that. And before we start the PowerPoint, my boss at the last minute wanted me to go over one little thing about co-managing with you guys. How many of you guys work for cataract doctors? Okay, so this won't, okay, so most of you, so that's good. So most of our doctors co-manage at least some, right? So we've gotten lots of phone calls lately from patients and from co-managers about the co-managers billing for the post-op care. So I want to go over what we're telling our patients and our co-managers, if you're talking to the co-managers as well. So how we actually bill that out, or it's supposed to be billed out, is that we bill the cataract surgery, or whatever surgery it is, most of the time it's cataract surgery, with a modifier that tells the insurance company that we are only providing the surgical care. And so we get discounted in what we're paid by 20 to 30% depending on the insurance company. So we don't get paid the full fee when we co-manage because we're going to bill only the surgery portion of that. We bill it with the modifier that says we're just billing the surgery. We're not billing for any post-op care. So post-op care accounts for at least 20% of anybody's fee for cataract surgery. And so we're discounted at least that. With one insurance, we're discounted 30%. So it's important to keep that in mind when we're dealing with co-managers. So the co-manager, on the other hand, bills the surgery fee, the surgery code, just like we bill, with a modifier that says they're only providing the post-operative care. That is how it's supposed to be done. We cannot, on a regular basis, pay co-managers. So if the co-manager says, that's okay, you guys pay us for that, the answer to that is no, we don't. We have done that a few times on a few occasions, but we will not, on a regular basis, pay a co-manager for the co-managing fees. That can't happen. We do pay them their portion of the upgrades. That's a different story. But for the medical portion, the actual surgery part of that, we do not pay co-managers for that. The co-managers bill for that. They're either going to bill, like I said, the surgery code with that modifier that says post-op care only, or they're going to bill office visits which really isn't the way they're supposed to do it. We have no control over how they're billing it, but we are not paying the co-manager.
So the reason we don't do that is because it looks like a kickback.
Yep.
That, hey, if you send patients our way, we'll send you
Yep.
some money.
So what has come up recently that we're not doing, or we changed, or why is this coming up
We have
recently?
had several arguments with
We're getting-
co-managers, actually, is the biggest thing that's
So
come
the
up.
We're getting a lot
co-managers-
of patients.
So
interactions.
they think we're telling them in clinic that we're gonna pay the co-manager, or where
That-
is
I don't know
the
where the,
confusion coming from?
that's what,
That's what we're trying to weed out because
Yeah.
we don't know. We're just getting a lot of patients.
yeah, we're just,
Joanne
I'm
might
just putting
have
the
some
information out there,
input
yeah.
So patients are saying they're being, they have to pay, what is it when they go in?
It should,
It's a, can't think of the term. So when you go in, you pay a copay.
Yeah.
Okay.
Except, so it's not just a copay. These doctors sometimes are charging $100 to $200 for a post-op visit.
Right, they're upset to us about
Right.
having to pay the copay.
okay, so the issue though is that you need to send them back to the co-manager because we have absolutely no control over what the co-manager bills. So if the co-manager is not, number one, if they're not contracted with their insurance, they don't need to be co-managing. So we need to educate our co-managers too. If they ask about that, or we're gonna co-manage, we probably ought to find out.
My whole question is, are we contacting like marketing to talk to Patrick so that
I
somebody
think,
can
I
close
think
the loop
Becky
with
is
the
talking to Patrick. I think
co-manager?
Becky has talked to Patrick.
Okay.
So that, we're just covering all of the bases. Becky wanted
Gotcha.
me to cover this space. So
That's
I'm
what I was
covering this
confused
space.
about. Okay, that works. That's fine. I just wanted to know
So,
what was causing
so
the
we just
issue.
wanna be careful how we're wording it. We just wanna be careful we're not telling patients that they won't owe anything for their post-op. So let's not tell patients that. Tell them they are gonna probably owe something for their post-op care. And we need, and if a co-manager ever says anything about us paying them for that, they need to be redirected. You can even direct them to call us in the business office if you want to, but we just need to make sure we kind of cut that off somehow, because that's a big deal with the OIG, which is Office of Inspector General. They are after co-managing. So we have to make sure we're doing it right on our end. We have no control over the other end, but we gotta make sure we're doing it right on our end. And a part of that is gonna be making sure we're not, I don't think we're necessarily giving out bad information, but I think that they're assuming bad information. And if we can cut that off at any point, we're ahead of the game, I think. So
Okay.
that's all I'm asking, is that if you hear something like that, try to stop. Stop and say, wait. So call the business office, they'll explain it to you. So anyway, so I've done my duty and fulfilled my job with Becky. So anyway, so we are going to talk about documenting insulin and non-insulin medications. So diabetic patients control the blood sugar in several ways, depending on several different factors. And it's important that we know what type of diabetes the patient has. Number one, do they have type 1 diabetes? Do they have type 2 diabetes? Is it secondary diabetes? And if it is, secondary to what? But we're going to talk mostly about type 1 and type 2 because that's what we get all the time. We need to know how they're controlling the blood sugar. We need to know what type of diabetes they have. So type 1 diabetes, they're always on insulin. I mean, I can't even think of it. I've never seen a patient that's actually type 1 and not been on insulin. Insurance companies are going to assume they're on insulin. We just need to document that they're on insulin. We don't necessarily need to bill anything, but anyway, so they're always on insulin. Type 2, it can be a myriad of things. It can be diet, it can be exercise, it can be oral medications, or it can be insulin. So important to know and document how they're controlling their blood sugar. We may or may not need to code that they're on insulin or other medications. Like I said, with type 1 diabetes, they're always on insulin, so no additional code is necessarily needed. We still need to document it. Type 2 patients with this diagnosis can be on, like we said, a myriad of different things, diet and exercise, oral medications, or insulin. If the patient is on oral medications or insulin, a diagnosis code is going to be needed on the claim in addition to the proper diabetes code, which is a type 1 or type 2 diabetes. So we have three choices. Patients use insulin. That's the code that we would use for that. I gotta turn my page. So that code reads, gotta get up there, long-term current use of insulin. If the patient is on oral medication, is long-term current use of oral hypoglycemic drugs, there we go. And if the patient is on diet and exercise, we're gonna document that too, but what code is there a code for that? What are we gonna code? Nothing. So, I got a little crazy with the English, sorry, I had to go take a bunch of them out. Anyway, so, if a patient is being treated with insulin or not, or other kind of medication, we're gonna wanna document it. We're gonna wanna circle it on the route slip, no matter what kind of diabetes they have. And then just let the billing department decide if a code needs to go on the claim or not. So we're just gonna focus on, we're gonna document it no matter what. We need it documented in the chart. And one of the reasons we need to document it in the chart is because of HEDIS. Yes?
Before we go further.
Yep.
We just were talking about this. We don't have the non-insulin medication code on the route slip. And I want to differentiate between a claim and a route slip. So when she's saying it doesn't need to go on the claim, that means you still circle it on the route slip.
Yeah.
We still want you to note it and circle it on the route slip. The claim is what they're sending into the insurance company. So I want to make sure it's very clear that just because she's saying don't put it on the claim doesn't mean
Right.
it doesn't go on the route slip.
Yeah.
I still want you guys circling on the route slip.
Yeah, put it on the route slip, we'll decide if it needs to go on the claim or not.
Right. So this non-insulin medication code, we were just talking about that. That's brand new information for me too. So this is
Just
fun
be very
little
It was a
clear,
new
someone's
code
on
with
that form and
ICD-10.
we circle non-insulin
right. But
and any other control other than
this-
insulin.
this medication is not on the route slip.
No,
Right.
So she is going to, in our
It'll
next
be on the
batch of
next
route slips, it'll be right underneath insulin use in the diabetes section. That's where we're gonna put it.
it will
So-
eventually show up. I'm not as worried about that code as much as I am the insulin
Not
code.
right now.
Right now, until
But
it
once
gets
it's
on the route
route
slip,
slip, we will be worried about it.
Yep, and I'll send out an email,
Thank you.
when we get it on the route slip to let you guys know that it's there.
Yeah.
And remind us that we need to use it, okay?
Yeah.
Is that good enough?
Yes.
taking both? Both.
Yeah, circle both, we'll probably just put the insulin on there. The insulin one is the most important one. And it's because of HEDIS, actually, is the biggest deal. So healthcare effectiveness data and information set, and this is a entity that is used by 90% of our health insurance plans. They measure performance of care and service, and that's whether it's rendered and billed. They gather information in the form of medical records to do that. They audit diabetic patients' charts very often, and that was their main focus when they first became a thing. So, after they audit those, what do you think that they do? They report back to their clients, and who are their clients? Insurance companies. And even worse, insurance companies can report back to
She was having
the
fun with it.
OIG. Okay, so insurance companies actually report back to OIG, which is, again, is Office of Inspector General. And if they see issues that we're not taking care of patients well, if we're not which we take excellent care of our patients, but if we don't document that well, they don't know that. So we have to prove that we're taking excellent care of our patients because we do that anyway. So, so let's just make sure we're documenting all of those things.
Before we go on,
Oh, yep.
can we
Sorry.
talk about that? Does
Yep.
anybody have any questions about that?
I
Before
just
we
have a
move to the
question
next
for like
section?
our injection page.
Mhm.
Does it matter? Because we don't do it now. Even if we have a diabetic patient, there's nowhere for that.
Yeah, no, if you're seeing them for an injection, don't worry about that.
Okay.
That's, you're not seeing them for that.
Okay, like I'll still circle it on the route slip, but I mean,
Right.
there's nowhere for me to document.
Right,
Yeah, no.
but when you have your exam, when you do those times in
Yeah.
between when you do an exam,
These are like
that's when you wanna
The-
document that.
Okay.
Yep. Yep,
So
okay.
Yes.
I have another question.
Sure.
For meaningful use, say someone comes in for a follow-up and it's noted no MDI in the exam.
Mhm.
Do we need to record diabetes on that? And, you know.
Okay, say that again.
So,
No,
so-
NDI is in the slit lamp exam.
Right, right.
She's talking
But-
about fundus examinations.
So it's only a fundus examination
Right.
that we need to
Right.
be coded
Right.
on
Right.
fundus. Okay,
Yep.
got it. That
Yep.
was-
Yeah, on their yearly diabetic exams is what we're
Okay.
talking
And
about.
that's the meaningful use
Yeah.
criteria as well, is those fundus examinations. Good question.
Right.
Good question about the injections. Any other good questions about diabetes? No? Okay.
I'm gonna hand it over to.
It's just a lot, so I would like to break it up and
Yeah.
give time for questions.
Yep. So I'm gonna hand it over to Megan, she's gonna talk to us about, the drug therapy, appointments.
So our clinic is really good at documenting that a patient is on like Plaquenil or any other high-risk medication. But the thing that we kind of fall flat on is noting what the systemic disease, like why are they taking this medication? And unfortunately, we can't bill a claim to insurance with just the code for the Plaquenil use. We need to tell the insurance company this is why they're taking it and this is why we're examining their eyes. So there are several places in the chart that you need to document the systemic disease. The first place that you're going to do that is in the chief complaint in HPI. So I see a lot of really good documentation with patient is here because they are on Plaquenil and they've been taking it for this long, but we don't put why they're taking it. So in that chief complaint you want to include, is it for Sjogren's? Is it for RA or for AIDS, lupus, whatever the systemic disease is. You also need to note it in their past medical history. So on that page, you need to document it there, and if you can, try to note also the year that they were diagnosed with that problem. And then finally, you want to put it in your plan and impression as well, because that's a key part of what insurance companies will audit if we ever get audited on a claim for this type of disease, is what's the systemic disease? Is there any plan that the doctor wants to do, or is it just no toxicity noted? But it has to have both the Z code, the Z79.899, which is high-risk medication, and then you also have to have the systemic disease, such as the lupus, RA, whatever. So a lot of times it's an N code for the systemic disease. So making sure that you're having both the Z code and the N code is really important. The one other thing that insurance companies are going to look at when they audit these charts is, was a dilated retina exam performed? If you do not do a dilated retina exam, we can't bill the Plaquenil use and the systemic disease, because it means we didn't look at the part of the eye that can be affected and can become toxic. So definitely make sure that you've got a dilated retina exam whenever you're seeing a patient for Plaquenil use or other high-risk long-term drug therapy.
So just to piggyback on that, sometimes we do see those patients for other things, you know, an irritated eye or something like that.
Right.
That doesn't mean we have to dilate that patient because they came in for an emergency because their eye was irritated. It just means that we as scribes need to note that we don't code for Plaquenil usage and lupus in that scenario, because that's not what we're going to bill for. We're going to bill for blepharitis or keratitis or whatever the situation may be, just for clarification purposes.
So the people that don't want to be dilated, but we've done a MAC, OCT, and the doctors actually looked at their eye, but it does not say that they were dilated, does that count?
The patient needs to be told if they refuse dilation that we can't bill that to insurance and it's their responsibility.
Okay.
So we have to, so one of the things we do with
Because we're
diabetic
required to
patients,
do that. So,
one of the things the doctors have instructed us to do with the diabetic patients is let them know that in order to fully assess the retina, they need to be dilated. If they would like to come back a different day and just do the dilation, they can do that.
yes,
So you're fine with
yes,
that?
as long as they do, and we
In-
follow up somehow and make sure that happens.
Well, we can't.
I know you can't
It's
like go get a
kidnap
patient
them.
and drag them in, but we just have to show that we've made an effort. And if you have
If
made
we're
an
coding
effort,
it, if we're billing it,
yes.
Right.
Okay.
Insurance companies, if they were to audit a chart that we did not do a dilated retina exam, they will throw that out, and that will drop down the code that we submitted to the insurance and potentially get us in trouble for, because how they'll look at it, it's kind of along the lines of where you guys can pick on the exam page, copy last exam. If it is a doctor that has not seen the patient and you all check that box, we as coders cannot bill to insurance. We can't count those, the fundus exam and the slit lamp exam if it's checked that way. Our doctors bring up the good point of, but I am assessing it, I am looking at it, we're just copying that information because it's the same. But insurance companies will say to you, you didn't do a new exam according to your documentation, and therefore you cannot bill for it. And that's what they're going to say if we don't do a dilated retina exam for a systemic disease patient that's coming in to check on their Plaquenil use. They're going to tell us, how do you know that it's not, that it hasn't become toxic if you didn't do that dilated exam?
So I feel like as scribes sometimes we'll hit copy last exam so we have a base of information because we're moving so fast, and then we'll change things along the way.
Right.
Does that,
Unfortunately, they only see the copy last exam. I was like,
Because
does it go
they
right
only
once I
see,
do it?
so here's why though. When we generate the document, that's what the insurance company looks at. They don't look at every template we have that changes to red. They look at the document, and the document says part of this exam is copied from such and such visit.
And
They don't look at our
it doesn't
templates.
stay red.
Yeah.
Once that encounter is locked, it all goes black. So they can't tell what we changed and what we didn't change.
So we can't.
So what about?
So
years?
that's why,
Yeah.
that's why when we train to scribe, we suggest you don't use that. We do have an issue with cornea because Dr. Mayer writes books, every exam he does. And if you don't copy the last exam, you will never leave the exam room. So,
Like,
But we
that's the
change
same.
it. We go in and
Yeah.
change it.
even though we do go in and change it, we modify it.
Right.
So that doesn't go away? That's what I was trying to figure out, like on the,
No,
Even
it
if
always
we
says
change stuff.
copy.
It always says copy
Yeah.
last exam.
And unfortunately, that's what they're gonna go off of. So, and we're at their mercy as far as
We are working on a compliance team to try to solve some of the issues that we're having with
Without
our
making it harder on you.
without making the clinical flow harder. So that may or may not change. So, but that's where we are right now.
So does it still apply if you hit within normal? Is that gonna ding against us and then we make
No.
adjustments? Okay.
Because copy last exam is the only thing that would indicate information was brought over from a previous eye exam.
Okay.
Yeah.
So is that just for high-risk drugs, or is that like gonna ding us on everything?
the copy last exam.
Yeah.
That's gonna ding us on everything.
So we need new exams every time then?
Before you change your flow and patterns right
Yeah,
now,
we're not changing anything yet. Don't do anything. Yeah, don't do anything
she's just
yet.
given us
I was just
additional
giving-
information to
I was just
enjoy.
giving you an example
Yes.
of how the insurance looks at what they
So would-
consider.
Well, I mean, for example, if you're doing, let's say you're doing a follow-up on a cornea crazy gunky ulcer or something, and Dr. Mayer wants to bring over that information, that's not as, we're gonna freak out, we're gonna get this much dinged off of us as Dr. Smith doing 15 complete eye exams in an afternoon. We should be using the within normal limits and putting in new information on all of those. So it kind of counters out a little bit, but I think what Megan is trying to express is if we get into practice habits of copying last exam, we're actually robbing ourselves in that scenario. So.
Yes, but don't change anything yet, please.
No, not yet.
Yes.
One day, and I'll let you know when that day
And
is.
you'll know because
But
it'll be a
right
big deal.
now, don't change.
Promise you won't miss that one.
Yeah.
The last piece of information that I have for you on systemic disease and high-risk drugs is if the patient doesn't know why they're taking the drug, it is our responsibility to find out what that reason is. So you can either check if they've got a family member in the room with them, you can check with them, or if they have a caregiver that you can check with. Otherwise, you need to go back to the primary care physician and find out why are they taking this drug, because that needs to be documented. So we always have to find out, even if the patient doesn't know why they're taking it, we have to find out that reason.
Well, and that's a good information for the doctor to have too, because different, depending on what that disease is, if it's Sjogren's versus lupus, I mean, those present in the eyes with different things, just the disease itself. So it's important to have that documented in the chart why they're taking that, not just so that
For
we can
billing
bill it,
purposes,
but because we need to
treatment.
close that loop. We can't just, I mean, we need to know, because what are we watching for just because of the disease, just because of diabetes? It's like coding a retina problem without the diabetes, or, you know, it's kind of a similar, it's not exactly the same, but we have to have the whole picture. So it's very important for the doctor to know they have Sjogren's. Very important for the doctor to know that they have lupus. It's, you know, important for the doctor to know that they have whatever else they would take Plaquenil for. And it's not just Plaquenil, we see other things, that's just the thing that we see the most is Plaquenil.
Yeah.
But,
I would think, just my opinion, I don't know if anybody else runs into this often, but I think most people, when you ask them what they're taking it for, do they know?
you would be, yeah, we've had,
Yeah.
run into it where we've had to go back to a tech and they're
Right.
like, they didn't know, I asked them and
Well,
they didn't
and
know.
every once in a while,
Yeah,
we'll
it's-
have that, I'm
right.
sure, but
But most of the time
I think the
you're good-
bulk of
yeah.
people usually,
But most people are gonna know why they're taking it.
if you, especially if you ask them specifically, they might not volunteer or
Right.
something,
Right.
but when you say, what are you taking this for?
Right. Yeah, so just make sure we're asking the question so we can get it in the chart.
Yeah, absolutely. If you suddenly have an uptake of people who don't know why they're taking it, let me know. Maybe we can look at a flow pattern for how we handle those scenarios, so we don't have to spend time calling PCP's offices. But
Yeah, we don't want to spend, that's gonna happen rarely anyway, so,
yeah.
it's gonna be a
It's
rare
just
case.
something that has come up. so
It
we
has come up a
wanted
couple of
to
times.
Bring attention to.
Before we move on
We
to
okay?
office procedures, does anybody have any questions about that? Systemic medications and stuff?
Oh, I have
Yeah.
a question sort of associated with that. So say you're doing a comprehensive exam, someone does not want to be dilated, they refuse. Are we still coding that as a comprehensive even though they
No.
weren't dilated? So
Mm.
so we don't code a level 4.
No.
What do we code?
That's a good question.
Depends on what was done.
Right,
You
so
can drop
we
it down
did-
to the intermediate code,
That's what I
depending
used.
So
on
the-
what you're seeing them for.
Got it.
Or you can drop it down to an E&M code that doesn't require a dilated exam.
I
Okay.
usually drop it down to intermediate myself.
Right. So if
Yeah.
they've,
Well,
if they've
as
gone through all the
intermediate
text
has
gone through all the
some
ancillary.
specific, with the intermediate, it has to be either a new problem or an existing problem with a new diagnosis management
Right.
issue. So it's worsening or they have a new symptom or
Right.
something like that.
Because the
So-
doctor will still do a fundus exam a lot of times if they have a few. And so
Right.
technically, the amount of time that we're taking in that exam is
I
exactly
understand
the
that, but it
Not
has to be through
dilated.
dilated pupils.
Okay.
The fundus exam cannot be counted unless it's through dilated pupils,
Okay.
or unless there's a contraindication. So if there's a contraindication to dilation,
Narrow
Right,
angles.
right.
you have to document that,
Okay.
and then you can get credit for the
And then
fundus
we can
exam,
go
yes.
ahead and code the
Yeah,
bullets.
but the patient refusing to do that is not a medical contraindication, just so you know. If your doctor
Right.
asks,
Yeah.
that's not a contraindication. So,
Sorry, really quick to back off of that. So for narrow angles,
okay,
we can code for the comprehensive
As long as the angles are noted.
as long as the angles are noted is what it sounded like.
So,
what?
like, she works in glaucoma, so she does a lot of narrow angle patients.
Oh, yes, yes.
So in that scenario,
Okay,
she can
sorry.
code for comprehensive
Yes.
if she notes the narrow
If you know
angles
that
as
the
well.
dilation is contraindicated due
Yeah.
to narrow angles or something like that,
So just
whatever
don't
your.
put like not required for exam.
Yeah,
Where you can choose that option for like
Yeah.
dilation.
Right.
Not
Type
required.
in
You'll need to type in narrow angles.
contraindicated or
Yes.
narrow angles or
and if we need to put some pics in there,
there is a narrow angle pick, I think,
okay,
in
yeah,
that one.
yeah, kind of the same thing with the IOPs. With the cornea issue, if you don't get an IOP because they have a foreign body, that's what you gotta put in there, just not,
Possible foreign body.
yeah,
or
we have
something
put
like-
possible foreign
But
body,
if you
that's,
just put not required for
Or-
exam,
or,
deferred,
then
or
we-
until
deferred,
after
we-
K exam, cause
We
we
can't.
it doesn't ever get documented after K exam,
So
so.
that's the thing, if you put, let's say you're working them up and you put after K exam, you need to put why you're saying after K exam.
Yeah.
Possible foreign body, possible ulcer, possible
Right.
whatever reason that makes you think you shouldn't evaluate them.
Right.
Not
Or-
just red eye,
If you know they have an ulcer because they had an ulcer before, then you can put that,
corneal ulcer,
Yeah.
yeah.
yeah. So, but we just need to reason, what is the contraindication to those things? Does that make sense?
Mhm.
Yes.
So, say we know they're taking Plaquenil, but for some reason they don't know what they're taking it for, does that mean we can't code for the Plaquenil?
Yep, pretty much.
We have
And
to try to
that's why
figure
we
out
gotta find
why.
out. It's gonna happen rarely, but we have to find out somehow
Okay.
why they're taking it. If we had, worst case scenario is we call the nursing home or we call the PCP, but hopefully that's not gonna be happening very often at all. And, but it has come up though, so, which is why we mentioned it, but it's not gonna come up very often, so.
If it starts to, let me know, and we'll
Yeah,
look
we can
at
figure something out.
how we can do that,
Okay.
It should be the exception to the rule.
yeah.
So, but we still can't bill, even though it's an exception, we still can't bill if we don't have it, so we still gotta find out. Okay, so office procedures, we talked about this a little bit, we touched on this the last time, but we're gonna go into a little bit depth because we're still having some issues here. So, but this is a confusing issue, so we're gonna go back over this again. So, required documentation, for, patient comes in for, and we're gonna do a minor procedure on them, but that's not what was planned necessarily. They're coming in for whatever else and something else, and they're coming in for, and you discover that they have this issue. Where we see this the most is plugs and epilations,
Yeah.
are the hardest ones to document.
So think about it this way. I mean, if you're coming in, you know you're doing a Chalazion excision, that's one thing. But these are people coming in with red eyes, irritated eyes, or it's their annual exam and they're like, oh, my eyes feel dry. They're not coming in for punctal plugs and they're
Right.
not coming in for ablation.
Right.
They're coming in for their annual or for their IOP check
Or
or
their diabetic